Next on the runway, we have Dr. Wenzel, who was already up here earlier today, so I'm just going to give him a brief introduction. Again, he's fully trained at Thomas Jefferson, and he remains on faculty there, where he's the clinical associate professor of anesthesiology on the regional anesthesia team. He also serves as the director of obstetric anesthesia, as well as anesthesia clinical director, and he will be speaking to us on phase blocks. Please join me in welcoming Dr. Wenzel.
Just want to give a quick shout out to Dr. Washek and say thank you for all your work in coordinating the meeting. It's been very, very fun. So what I want to talk about today is tackling the sphenopalatine ganglion. So sphenopalatine ganglion block has been around for a long time, of course. It's not something that I saw in my practice or in my training until relatively recently. And I'm curious, by show of hands, is anyone doing SPG blocks in the operating room for any cases? How about for post-dural puncture headache? Okay, so it is definitely interesting, and we'll go through some of the advantages, eases, uses. So our objectives will be to identify the relevant anatomy and physiology of the sphenopalatine ganglion, also called the pterygopalatine ganglion, so we'll be using those interchangeably. We'll probably just stick with SPG to keep it simple. We'll discuss some of the technical details of performing an SPG block with an ultrasound-guided approach, and review the indications and the clinical effects and benefits. No disclosures, but I, like Sean, I'm always looking for them if anyone has any. All right, so the sphenopalatine ganglion, also known as the pterygopalatine ganglion, or the Meckel's ganglion, or the hay fever ganglion, because stimulation of this ganglion will give you the runny nose, the watery eyes, etc., amongst other things. It is triangular shaped, situated below the V2 branch of cranial nerve 5 within the pterygopalatine fossa, bordered by the maxilla, the palatine, the sphenoid, but it's a kind of a keyhole-shaped fossa that is open laterally. Its role in pain was first described in 1908 as sphenopalatine neuralgia, and we'll talk about some of the innervations in just a moment. So overall, this is a parasympathetic ganglion composed of sensory and autonomic nerves. Sensory and sympathetic nerves traverse it, but it's the parasympathetic that actually synapse and has postganglionic parasympathetic fibers that originate from it. Here's just to visualize some of that bony anatomy. As you can see, lies in close proximity to other structures, including the trigeminal ganglion, maxillary nerve, maxillary artery and branches of the maxillary artery, the internal carotid a little bit further away. But when we look at the technical details, we'll see how this bony anatomy is relatively easy for us to take advantage of on an ultrasound-guided approach. And here's just sort of one other picture of where it lives, kind of behind the maxillary sinus, behind the middle nasal turbinate. So in terms of innervation, sensory fibers from the maxillary branch of trigeminal nerve pass through the SPG, so some innervation of the nasal cavity, the palate, the parts of the pharynx. So performing a block in this area can be helpful for certain mid-phase surgeries. In terms of autonomic, sympathetic fibers travel through without synapsing. However, the parasympathetics have secretomotor function to the nasal mucosa, the lacrimal glands, so of course the tearing, the runny nose, as well as vasomotor to meningeal and cerebral blood vessels. So not only pain, but pain, lacrimation, and we'll talk a little bit more about how that vasomotor component really plays in with headache physiology. So really a central role in cerebrovascular autonomic physiology and the pathophys of primary and secondary headache disorders. So without going into a whole other talk on headache, with headache pathophys, you have an afferent stimulus, you have parasympathetic activation of meningeal vessels, lacrimal glands, the nasal pharyngeal mucosa, and you get a headache. That's why, cluster headache, migraine, a major portion of the treatment paradigm is tackling vasoconstriction and trying to stop some of that vasodilation. I do a lot of obstetric anesthesia. Drs. Huffnagel taught me how to do epidurals, and though I try not to disappoint them and never have an inadvertent dural puncture, it's happened once or twice over the years. And Monroe-Kelly doctrine being what it is, if we have a loss of CSF that gets replaced by blood, so this isn't exactly the same physiology as primary headache disorders such as cluster or migraine, but we can also see, we already know how that vasomotor component and that compensatory vasodilation is a major, major contributor to the headache of a post-dural puncture headache. And if we have the ability to reverse some of that phenomenon, would obviously be a very nice, attractive option for a treatment. So the SPG has become a therapeutic target for some varied reasons with different approaches. Now, in terms of some of the indications, headache disorders, of course, migraine, cluster headache, and then the one of particular interest to me, as I mentioned, would be PDPH. Certain facial pain syndromes, facial neuralgias, awake nasal fiber optic intubation. And what we've started doing recently is surgical analgesia. So for certain mid-face surgeries, such as palate endoscopic sinus surgery, tonsillectomy, Le Fort, things like that. The reason this came to our attention at Jefferson is studying headache after subdurals. So they wanted to look at trying to ease the headaches for those patients. So then, in addition to the study parameters, we started asking questions about, what else is this really used for? Because even though, this has been identified as a target, long time ago, and there have been approaches to blocking this over the years, it's something we never did, especially in an ultrasound-guided approach, which seems to have some good advantages. In terms of contraindications, not too many. It's considered kind of an intermediate block for risk block for anticoagulation purposes. So normal hemostasis would generally be recommended. Allergy, of course. History of facial trauma or infection for fairly obvious reasons, and then patient refusal, of course. And counseling a patient about putting a needle on either side of their head may or may not be a very easy conversation to have. Depends on your patient. Complications in general are relatively small. Little bit of skin bruising. You do expect to get some degree of a maxillary nerve block and a trigeminal nerve block. So if you were doing this for headache physiology, you would counsel the patient about, expect a certain degree of numbness, especially on parts of the palate. But that's just more for the counseling. Now, when it comes to the technique is what makes this attractive as an ultrasound guided. So the transnasal topical has gotten some attention over the years. There was a thought that the long Q-tip applicator with some viscous lidocaine would be a good alternative to an epidural blood patch, or whenever an epidural blood patch seemed too risky for a second puncture or something like that. Cotton-tipped applicator. It's kind of like a COVID test. The patients I know that have had this do not think it's very comfortable. And although there is an opening for diffusion there, it's just not a very easy and effective way to do this. You really have to land your applicator, as far back, into the nasal mucosa as you can, and you're relying on diffusion through a pretty decent distance. So a little bit more hit or miss in terms of effectiveness, and not comfortable to place. Radiofrequency ablation or pulse radiofrequency, something more for the chronic pain realm, not what we would be just doing in the operating room. The transoral approach, more in dental practice, so a little more direct, but this is a needle-based invasive approach that most of us would probably not feel super comfortable doing. The infrazygomatic approach is an in-plane approach that has more potential complication. Basically, it's a posterior to anterior approach, so you do have risk of encountering the orbit. So again, if you're not specially trained in doing this, the infrazygomatic approach is probably not for you. The ultrasound-guided suprazygomatic approach, however, more reliable than the transnasal technique, a little bit more involved because it actually is an ultrasound-guided needle approach as opposed to just that applicator, but something that could be in the realm of most anesthesiologists' practice with pretty easy ultrasound use. So what's generally involved with this, this is just a little editorial I loved from a few years ago. Topical intranasal lidocaine is not a sphenopalatine ganglion block. So we'll try to talk about the little bit more effective way to do it. In an awake patient, a 25 gauge spinal needle would be recommended. And in a sleep patient, you could also use your standard block needles at 21 or 22 gauge, but the 25 gauge spinal needle is really sufficient. The injectate is pretty small, 5 mLs on each side. So usually 4 mLs of relatively concentrated ropey or bupi, with or without the addition of dexamethasone. If not, it could just be 5 mLs of the local. This can be done bilaterally and is usually pretty quick to do in the same sitting. What's very interesting is the effect of the injection far outlasts the expected duration of the meds. So we might expect a bupivacaine or a ropivacaine to last about 12 to 14 hours. In the primary headache disorders, you can see benefit well into the weeks, and often for a post-dural puncture headache, it is curative, and it's very rare to have to repeat this or do a subsequent blood patch, except for some reason if it wasn't the right target or there was another reason the block may have been ineffective. This can also be diagnostic or therapeutic. For most of us in general practice, we would be doing this for therapeutic purposes, but there could also be a diagnostic role if the patient were being considered for radiofrequency ablation. So we'll kind of quickly go through the technicals. I borrowed a lot of these photos from Jeff Gadsden's videos. I love his regional anesthesia YouTube channel. I'm sure several people in the audience have seen it. Really, really high yield, makes it very easy to look at new techniques, or if you're less familiar, reviewing older techniques. But the margins we're really looking for here are the posterior aspect of the orbit and then the zygomatic arch. This can be marked out, but isn't necessary, especially if you're just learning, it's helpful. This is the probe position under the zygomatic arch, tilted a bit cranially. The needle is going to enter with some approximation, maybe about 1 centimeter behind the orbit and above the zygomatic arch, and the needle is directed somewhat caudally. So you would kind of picture this orientation, the needle tip meeting the laser beam at about, the ultrasound beam, sorry, at about 4 to 5 centimeters. I have talked to some people who are very comfortable with this that end up doing it blind. They basically, this needle insertion point is the same. You generally aim the needle towards the tragus of the contralateral ear. You are likely going to impact the sphenoid and then just walk down. And once you've cleared the sphenoid inferiorly, just stop in at 5 centimeters and injecting. Just generally speaking, the needle will get close enough. But we'll review the ultrasound images, which are relatively straightforward. So again, this is the position of the probe over the bony anatomy. Slide a little cranially, caudally, medial, or laterally as you need to. But this would be the image you're looking for, which is relatively easy to find. So posteriorly, you're going to have the coronoid process. Anteriorly, the maxilla. You'll be traversing the infratemporal fossa. And then the bony backstop is the lateral pterygoid plate, which in an awake patient, you try not to impact because it can be uncomfortable. In a sleep patient, they wouldn't feel it, of course. But one of the reasons this is considered a pretty safe block with low risk of complications is it's very difficult to get anywhere else. You're not going to approach the orbit. You're not going to find your way into the dura. If all of the stars aligned, you might be able to find the middle nasal turbinate if you were kind of really a little bit off. But again, you're going to end up having meds come out the nose. But most of us would absolutely not want to impact the orbit. So relatively straightforward. And then when your needle comes in the orientation we saw earlier, 4 to 5 centimeters, kind of in your target right here in the infratemporal fossa. And then you can do that bilaterally, very easy. So just another orientation of how you might have the patient positioned. We've been doing them asleep for several ENT cases and OMFS cases so far. I have yet to do one on the awake post-dural puncture headache patient, but I'm sure it's coming. Speaking of that, just because that's an area of focus for me, blood patch, of course, remains the gold standard with a very high success rate, not without some degree of risk of possible adhesive arachnoiditis. Back pain, we know that back pain, even if temporary, is extremely uncomfortable. People don't like laying flat after they have difficulty laying their legs flat. It's not very comfortable. And then, of course, we're always thinking about, well, what if I just do this again? What if I've made it no better? So in a training institution, a lot of junior residents. So when it's situational and related to a new trainee in an otherwise easy epidural, those are easy blood patches to do. But as we all know, the patient that was difficult in the first place for habitus or scoliosis reasons, it's not going to be an easy blood patch either. And then trying to arrange with chronic pain or an interventional neuroradiology team, the things we already know, delays milestones, delays discharge, longer length of stay, very unhappy patient who's trying to, get used to being a new parent. versus the SPG block. And once you get over that hurdle of telling someone that you're going to be doing awake needles in their head, just think about positioning. We tend to sit our patients up for their epidural blood patches, making the headache worse in the short term, or you can try to do them lateral, not as technically easy. So maybe the headache isn't as bad, but the patient's more uncomfortable. And in the patients I have counseled about this, no one's opted in for it yet. I really just liken it to being a Botox needle or an acupuncture needle to try to make it seem a little bit more palatable. Get it? Palatable. So with this block, you're blocking the parasympathetic flow to the cerebral vasculature. So with that cerebral vasoconstriction and attenuation of nociceptive stimulation, minimally invasive, allows direct target to delivery. Limited studies, the last time we tried to pull at SOAP to see if anybody was doing this, does not seem to be super common, but I think as more people learn, pretty easy to do, I could certainly see it being more common. And the list is pretty long. I'm just about out of time, but you can see the headache disorders, facial pain syndromes, a lot of things this may very well be useful for. And again, something that's relatively easy and straightforward to do. And thank you all again for your time.